So let's take a look at performing some ultrasound exams inside of a moving helicopter, specifically the 407. Just because we know that this is going to be a challenging environment to try and perform it in, we want to demonstrate just the feasibility of actually being able to do this. These are, of course, exams that you can also, not only can you, but you definitely will be performing these in the ambulance or in the hospital as well on patients, but you want to be able to reevaluate during flight, right? And make sure nothing's changed. Perhaps you had diminished breath sounds in the ambulance, not significant enough to DART, but maybe it's a developing pneumothorax, maybe it's developing tension physiology, so you want to be able to reassess that. Or you have a patient with weakening pulses or you can't feel a pulse anymore. And so you want to be able to do that subxiphoid view to watch for cardiac function, right? So very simply, we're going to lay the patient back like you've just seen here. I'm going to use the ultrasound app on my phone instead of the iPad, just because I think just because it's smaller and easier to manage, easier to hold. So one key distinction, remember, about the subxiphoid view is that when you're coming in, it's not, you have to find the xiphoid process first and foremost. So I usually start with my probe here on the sternum and just slide down towards the feet until I feel the probe drop into the abdominal cavity. I now know that I'm below and inferior to the xiphoid process, but I'm not behind it yet. And one key feature and one key component to perform this exam successfully is actually coming down and scooping up underneath the xiphoid process. So you can see here on our view, we already have a really great view of all four chambers of the heart. Just this right here. This isn't going to be something that's extremely diagnostic of detailed cardiac function, but it is enough to say, oh, this patient's heart is beating. And also, if we're concerned for trauma or anything that could cause a pericardial fusion, we can be monitoring for that, any fluid in between the heart and the pericardial sac, and potentially even signs of tamponade. You can kind of continue looking around here, moving a little bit, if you want to try and visualize all four vessels. Here with Brian, we actually can get a pretty decent view of all four chambers, not vessels. And here we do actually have a pretty good view. You can see the right ventricle there is going to be the chamber that's closest to the probe, so the one at the top, and then the left ventricle is behind it towards the bottom of the screen. Smaller chambers next to that are going to be the atria, and you can actually see even the mitral valve there in between the left atrium and the left ventricle. One key component that I always like to point out, and this is a really good view to show this, is the difference in how the left ventricle and the right ventricle contract. So the right ventricle, with how the muscle fibers in it are aligned and how they're structured, the right ventricle actually shortens and lengthens with every single contraction, which you can see happening here. Again, that's the ventricle closest to the probe, so at the top of the screen right now. Versus the left ventricle, the muscle fibers are arranged concentrically surrounding the ventricle like a circle. And so the left ventricle, instead of shortening and lengthening, it actually squeezes in on itself, gets a smaller circle and a bigger circle, smaller circle and a bigger circle. That's something that you can actually see happening right here, right over here, is that left ventricle getting bigger and smaller, and right there is the right ventricle shortening and lengthening. So anytime you're looking at the heart from any view, if you're having trouble figuring out which chamber is which ventricle is which, that's always going to be super helpful for you to understand how those chambers of the heart actually contract and be able to figure it out that way. So let's say you're in the subxiphoid space and you confirm cardiac function and you want to assess for fluid status. Later on next month, we're going to talk about, in the next video on ultrasound, we're going to talk about some more specific indications for why you would perform some of these exams. Right now, we're just covering how to perform them. So next up is going to be how to assess the IVC, and specifically looking for collapsibility. So from that subxiphoid space, you're going to rotate your cursor so it's pointing towards the patient's feet until you find the IVC. And there it is. Well, actually, I've ultrasounded Brian before, and I know that his IVC also is pulsatile. Sometimes people have a pulsatile IVC, sometimes they don't. You can see it right there pulsing a little bit. And over on the right side of the screen is where the IVC joins the heart at the right atrium. If I come back over just a little bit to the left, we see this vessel right here instead that's also pulsing, but a much more strong pulse, less wave-like. So that's obviously going to be the aorta. Anytime you perform this exam, just think about your anatomy and remember that both the IVC and the aorta kind of run close to the spine at the back of the thoracic cavity and the abdominal cavity. The aorta is going to be a little bit more to the patient's left, and the IVC is going to be a little bit more to the patient's right. So, Neil, if you want to come in here, look at the probe real fast, anytime you're performing this exam and you're not sure which vessel you're looking at, just kind of fan your probe like this. If I'm looking more towards the patient's left, I'm eventually going to find the aorta. right here, just like that. And if I come more towards the patient's right, I'm going to find that IVC, maybe still pulsatile, but looks more wave-like, looks more fluid, right? So that's how we know. All right, so from here, I find that junction. We can also see Brian's hepatic vein popping in and out of view off of the IVC right there, going into the liver. That structure closest to us is the liver. And the liver is actually your best friend when you're trying to perform ultrasound exams of the abdomen or really even the chest, because it's a very fluid-filled cavity. And as you remember from the demonstration we gave you just a minute ago, the ultrasound waves love liquids and they hate air, they hate gases. So with how much blood is always in the liver, how much volume of our blood it holds, it does a really wonderful job of resonating those ultrasound waves and strengthening them to give you a better view of whatever's behind it. So that's what we're seeing right here, is we're actually seeing the IVC through the liver with a better view. So just a little side note, anytime you're struggling to get a subxiphoid view on a patient, you know, I told you, you want to start off just dropping in right here and seeing underneath the xiphoid process and scooping. On some patients, that's not going to be good enough and you're going to struggle to find that view. So you can actually slide down a little bit and to the right and use the patient's liver to help echo that view. And so now you see I'm still looking at Brian's heart through a subxiphoid view, but half of the top of my screen right there is liver, and I'm using the liver to look through it and find the heart. So anyways, let's go back to that IVC view. What we're looking for here is whether or not the IVC collapses. Does it stay completely full? Does it collapse, or does it stay about the same? So let's get that good view of it right there. And specifically, this works best with a spontaneously breathing patient. So once you have that view, you're going to ask the patient to sniff. So Brian, perfect. So you see the walls of the vessel right there, and we're going to zoom in just a tiny little bit. You're looking to see how much they collapse. So in this view right here, the IVC is already a little small, but I would definitely call that, Brian, give me another sniff. You see the walls of the IVC pretty much touched right there. So that, I would say, is a sign of dehydration. Well, not I would say. That is a sign of dehydration. And if you are trying to evaluate whether or not a patient who's hypotensive would be fluid responsive versus needing pressors, this is a wonderful exam to do that, to be able to make that decision. So right there, we see an IVC collapse down greater than 50%. Good sign that the patient will be fluid responsive if they're hypotensive. Alternatively, if it stays real fat and it doesn't collapse at all, that's going to be a sign of a fluid overloaded patient. On some patients, when you're performing this exam, sometimes, like with Brian here, it's best to look at the right atrium, where the IVC joins the right atrium. Other times, it's better to move your probe down a little bit and look at more of the abdominal part of it. It's going to depend on, every patient's going to be different, and it's going to depend on the views that you're able to find. We have such a clear view right here that this is definitely a prime spot to look. And that's such a good view. Brian, give me one more sniff. Yeah, pretty collapsible for sure. All right, so let's take a look at some pulmonary exams real fast. There's two different pulmonary exams that we can perform. The one that I can imagine occurring most commonly in flight is assessing for developing pneumothorax. Obviously, an ultrasound is not going to tell you whether or not there's tension physiology, right? All it can tell you is if there is a pneumothorax or not. Once you've made the determination that there is a pneumo, you have to then assess the patient clinically with, tracheal deviation, poor hemodynamics, poor cardiac function on subxiphoid, something else that tells you that pneumothorax is causing tension. Because we know that most pneumos, something greater than 90-95% of pneumothoraxes, are simple and not causing tension physiology, thereby not requiring darts or any kind of intervention in the chest. So we're going to take a look at that first. The best places to look for this exam are the same places that you would dart someone. So that second intercostal space, mid-clavicular, remember that's further lateral than people tend to think. Where the nipple line is right here, we're going to be even past the nipple line. And the other best place to assess for pneumothoraxes is the other place you would dart, which is fifth intercostal mid-axillary down here as well. So we're going to look right here to keep it simple. Let me unfreeze my view. And what you're doing here is you're trying to get inside of a rib space. So you got to feel kind of what the direction of the ribs are. And so usually up here on that second intercostal space, they're pretty parallel or perpendicular with the chest, right, going like this. And so with that rib space, you want to make sure that your probe is perpendicular to that rib space, not off at an angle and not following it like this either. You want to be looking between two ribs. So you're going to find that spot. And we see those black lines coming down. Those are rib spaces or rib shadows, actually.
Yeah, but
And we're going to kind of look around and just find a rib space that we really like. And I really like this one right here. So I'm going to zoom in a little bit. And what we're monitoring for right here, just in this basic mode, is up here at the very top, we see this really bright white line. It kind of slides back and forth. And Brian, take some big deep breaths for me. And you can kind of see, it's hard to say, but you see that white line sliding back and forth across. And that's the two pleuras sliding against each other. It's called the lung sliding. That's a good thing. That's what we want to be happening. To give it a more definitive view of this, we're going to enter M mode. Stands for motion mode. So again, it's going to be the same as before. You're going to find that view, and I happen to already be here. Up top, you see I have this yellow cursor that I can move back and forth. And that is going to give us a snippet of wherever that cursor is. That's what the bottom half of the screen is. So right now I have the cursor over the rib space, and so that's why it's giving me mostly black and shadowy images at the very bottom. I want to put that cursor right over the rib space. And really what we're looking for here is something called Seashore sign. That's what we do have with Brian here. And we don't need to be that deep. We actually want to be pretty shallow with these pulmonary exams. So I'm going to zoom in a little bit, move that cursor, and just nice breaths for me. Keep breathing. And what you're seeing here, it's going to be hard to differentiate. And this is one of those things with ultrasound is you have to see 1,000 normals to really recognize abnormal, because anyone could really argue that this does look a little barcodey versus Seashore sign. But Seashore sign is a positive finding. That's good. That's what we want. That means that the lung is sliding in a normal fashion, and there is most likely not a pneumothorax. We identify that with, let me readjust my probe here. With at the very top of the motion picture at the bottom, we see the sky. So we have a horizon and we have a sky above that. Then we have kind of an ocean and a very beachy view at the bottom that looks very sandy and grainy. Versus, and again, it's hard to replicate a pneumothorax on someone to really show you what barcode sign looks like. We'll put in some pictures to demonstrate that. The best I can do is tell Brian to take a deep breath and hold it. And as he stops breathing, the motion goes away and it looks a little more straight across. Start breathing again for me. Versus now you see it's more grainy. You can see that breathing pattern occurring on the motion mode. Let's take a look somewhere else at the bases of the lungs, and perhaps that'll give us a better idea of what a Seashore sign really looks like.
And is that the features? You feel it today?
So remember, like I said, you want to be perpendicular to the rib spaces here. So here you got to feel where the rib space, the angle of the ribs, and make yourself perpendicular to that. So we have another really good view here, and you can see those really bright white lines. Those are the pleuras right there. So I'm going to put my cursor right there, and let's see what this looks like. That is a much better demonstration of Seashore sign. That looks much more grainy, and a much clearer distinction between the horizon and the sky up top and the ocean versus the grainy beach at the bottom. So now big deep breath and hold it. Stay real still. And that's not a great representation of what a pneumo looks like again, but it's a little more barcodey, a little more straight at the bottom. So you can breathe again for me. And there we go, much more grainy. So hopefully that's a good representation for you guys. The other exams that we're going to perform for the pulmonary, for the respiratory system is the assessment of B lines. We're looking for pneumonia or fluid on the lungs from pulmonary edema or whatever else may cause fluid to collect. The best place to do this is going to be at the bases of the lungs where we just were. And obviously, Brian is a healthy person that is not going to have pulmonary edema, but sometimes most everybody still is going to have a B line or two, and that is completely normal. So I'm going to try and find those for you guys. All right, so not able to find any B lines to demonstrate to you guys what those look like. At this point, you've probably seen pictures or videos of them from other resources of what they do look like. The best way to describe them, there's a couple different ways. Some people call them comet tails. They look like they're shooting down vertically from the pleura down into the thoracic cavity below. You can also describe them as kind of light coming through a stained glass window in an old, like, dusty church. To be indicative or diagnostic of pulmonary edema or other causes of fluid on the lung, you're going to want at least 3 to 5 comet tails in one singular rib space. And you're going to want that over multiple rib spaces in at least 2 different lobes or areas of the lung. So if I were to find one B line on Brian, that would not be diagnostic of pulmonary edema or anything like that. I would need multiple in one space, and there you saw a flash of one for just a second. There's some more right there in this rib space that we're seeing just a little bit off there to the edge. So if Brian right now had shortness of breath, extreme work of breathing, requiring BiPAP, other types of support, and I was trying to work him up for COPD versus something cardiac or something else, trying to figure out what my etiology of the shortness of breath was, this would pretty effectively rule out a cardiogenic shock, a cardiogenic component or cause of that shortness of breath, and lead me more towards his history of COPD or asthma or whatever other clinical assessment tools I might have. All right, so let's take a look at Morison's pouch now. This is going to be for a trauma exam. We're looking for any type of fluid collection in the abdomen, and specifically we're looking for in between the kidney and the liver. So we kind of already have the view we want here. One key teaching tool that I found with this is that you're still going to be looking in between rib spaces. Morison's pouch is not way down in the abdomen below the rib cage, but actually still protected by the rib cage. So it's going to be very similar to performing a pulmonary exam, where you have to be able to look in between ribs, which can be a very limiting factor. It's just going to be further down towards the patient's feet. So we're coming in here, and boom, just right there like that, you see the patient's kidney right there in the center of the view. Surrounding it up here at the top and to the left, all up here, is the liver. That is the junction of where the liver and the kidney meet. And right now they're touching. That's normal, right? Typically speaking, the liver kind of rests on top of the kidney and everything is good to go. In the case of trauma and intra-abdominal free fluid, you would see a collection of blood in between those two structures, in between the liver and the kidney. This isn't going to be able to identify the source of the bleeding by any means for you unless it's super bad. And just so you can see, by the way, you can kind of see all of that vasculature that's popping in and out of the view over there in the liver. That's just one little, another piece of assessment data that you can use to really identify what structure you're looking at. The liver is always going to be a very vascular organ, looking just like that. So anyways, you're coming in, you're coming into that rib space, maybe 11th, 12th rib space, something like that down here. You're going to have to scan up and down. Again, you want to be perpendicular to the angle of those ribs. So his ribs right here are running actually kind of like this. So I want to be a little bit more like this. And there we go. There's ribs. I'm having to look in between ribs. Those are the shadows coming down from the top of the screen. But I can see where the liver and the kidney meet, and I don't see any free fluid. Good to go. That's an assessment of Morison's pouch. Next up, we're going to look at the bladder. In males, you're looking at the bladder. In females, you're also going to be looking for blood collection behind the uterus. This may require a little bit more depth, just depending on the size of the patient. All right, so now we're looking at the bladder right here. We see a pretty full bladder. Like I said, he was dehydrated earlier. He's about ready to pee it all out. This actually has the ability to be able to estimate bladder volume. So any of the nurses here that are familiar with doing bladder scans inside the hospital, it's the same concept right here. The AI technology in here can determine the size of that, can measure the size of it and tell you how many milliliters of urine it's holding. Not something we really care about right here though. What we're looking for is, obviously we see a collection of fluid inside of the bladder. We can assume that to be urine. What we're looking for is a collection of blood behind that bladder space. So down here in this area right here, if we were seeing another black spot beneath the lining and wall of that bladder, that would be a sign of more intra-abdominal free fluid and presumably bleeding if it's a trauma patient. So once we have that, we're just going to take a quick look up and down. Again, if the patient is a female, there's also going to be a uterus, and so sometimes you're going to see blood collection in between the uterus and the bladder. Not something I can demonstrate here, but again, you will always be able to identify two clear structures. The uterus also will have a little bit of black space inside of it. Very normal. It's going to be much smaller than the bladder. But again, find the wall of the uterus, find the wall of the bladder, and then look for any fluid collection in between those walls. They should just be touching with no space in between. One other exam that, again, I can only mildly replicate for you on Brian here is the assessment of fetal heart tones. So what I can find is his abdominal aorta right here. You see it's that black circle in the middle, very slightly and gently pulsating. So let's pretend that Brian were a pregnant patient and I was trying to perform a fetal heart tone assessment in the helicopter or a bedside. We're going to find the vessel, and let's say this is actually the fetal heart that we're finding inside of the womb, inside of the uterus. We're going to go into M mode again, and we're going to use our cursor and place the cursor directly over the beating fetal heart that we see. We're getting, unfortunately with this, we're getting a lot of respiratory artifact. All right. So, first things first, this is why it's important to always have your cursor in the right orientation. I have my cursor flipped, and so when I was over that vessel that I just lost it a second ago, I had my IVC and my aorta confused. So, we want to make sure that we have that properly. So, now we see right here, this is IVC. And so you see when I try and put the M mode over that, it's just a wave because that's how the IVC functions, right? It's a much looser, weaker wall. So it's just a wave of fluid constantly going up and down. Versus over here to the side of it is the aorta, the abdominal aorta, and that's gonna be much more pulsatile. So cursor's on that. Down here at the bottom right, you see this little film button. We're just gonna press film. That's gonna take a 5-second strip. After those 5 seconds, you can go back to this exam view right here, come down and find your recording and count. With a fetal heart rate that could be, close to almost 200 in some instances, it can be really hard for you to count the beats in the moment. But here with a heart rate that's, probably in the 60s to 70s, it's much easier to just on the M mode look for the blips that are occurring down here. And so I can just have 5 seconds on my watch and just count out 1, 2, 3, 4. And I see that those beats are occurring almost with every single white dot above it, which is 1 second at a time. And I can tell you that his heart rate's just a little bit over 60 right there. All right. What else?
Down. Which the film? Into it. Right. It was before I thought. Good. After.